Now that you've seen a little bit about what epidemiology do in the study of epidemiology, let's review a couple terms that you're going to be reading about in this week's um, textbook. So, epidemic, we're all pretty familiar with terms, probably epidemic, endemic, and pandemic. You maybe just don't realize the difference between them. In an epidemic, we have an unexpected large number of cases of an illness or a specific health related behavior or event, but it's within a particular population. If something becomes an epidemic, it may also be described as an outbreak. Outbreaks typically differ from epidemic in that they're in a more limited geographical area. When the term endemic is used, it is referring to a disease that occurs at an expected level within a population or a certain location. So, for example, the seasonal flu is an endemic disease process that we expect will hit the northern hemisphere during the winter months. Pandemic is an outbreak over a wide geographical area. So the COVID-19 pandemic affected multiple countries and areas all around the world. Looking quickly back at the history of epidemiology, it can be traced back to Hippocrates in 300 BCE. Throughout time, there was few advances that were made after the fall of Rome and Greece and their more classical civilizations. After the fall of these empires, there was subsequent waves of infectious diseases and epidemics, like we talked about the other day with plagues, yellow fever, cholera. By the 1800s, we started to see some improved growth in the field of public health and epidemiology, with Dr. Rush in 1803, located in Philly, tracing cases of yellow fever to the shipping docks that were receiving ships from tropical ports, as well as in 1849 from John Snow, as we talked about the other day, tracing cholera in London to a specific water pump and using a natural experiment by tracing the cases to figure out what was causing that outbreak. From then forward, we started to see more advances and continued growth in this area. When we talk about epidemiology, we oftentimes refer to different rates. And these rates are going to give us information about the outbreak, about the epidemic, about the pandemic, and allow us to track data. For example, cases are going to be referring to the number of people who are sick. Rates are looking at the number of events in a given population. So, not the individual people, but the different events, such as things like natality, which is the birth rate, morbidity, which is a sickness rate, and mortality or fatality, which is a death rate. And we'll talk about those a little bit more in the future. You can also see rates related to population at risk, which is talking about the population of people who might be more susceptible to contracting a specific disease or condition. Some other definitions of rates would be an incidence rate. This is the number of new health related events. And number is divided by the population that is at risk. This is important in the study of acute diseases or diseases that are new and affecting people right now, new to them and affecting them. Oftentimes in acute diseases, there's a peak in severity of symptoms, but that it stops within days or weeks. Attack rate is not a rate that is always calculated and reported for specific diseases. However, the attack rate, when it is calculated, is tied to a specific place, event, location. So, for example, if there was a rise in um, Ebola, let's say, linked to a specific concert, then the attack rate might be reported. The prevalence rate is the number of new and old cases and divided by the number of people in that population. So this rate, the prevalence rate, is very useful in studying chronic diseases. And chronic diseases are going to be diseases that are lasting more than 3 months or longer. So, for example, if we're looking at the prevalence rate of diabetes affecting a population, this table comes out of your textbook and it shows how those numbers are calculated. When rates are interpreted, sometimes they are adjusted to look at different measures or to give more information. So, for example, if it's a crude rate, it's a rate including the total population. Whereas if it's age adjusted, we're looking at just different age groups. So, for example, if you're looking at the overall number of individuals who have cancer, that would be a crude rate versus looking at age adjusted rates. And this could be really important. So, for example, something like lung cancer has a higher prevalence in individuals who are older. So, you would really want to look at an age adjusted rate because that number would look significantly different if you were looking at children versus young adults versus middle age versus older adults. When we talk about specific rates, some are required to be reported in the United States. And some examples of this is birth rates. There is some really interesting information if you look in your textbook on page 65 that looks at what is collected when somebody is born. I think it's pretty eye opening the amount of information that is collected about each individual. So, birth rate is a required reporting, so natality. Also, death rates, so mortality or fatality. And certain diseases. If you look at pages 63 through 65 in your textbook, you can look over the list of the current required diagnoses that are required to be reported. Please note that this book was published just before COVID-19 pandemic, so some of this has changed slightly. There's some more diagnoses that have been added. But these 3 rates are required by physicians, hospitals, and clinics to report events related to this to the CDC, so the Centers for Disease Control. There is an integrated surveillance system that is used. You can see information regarding this on this slide here. And that information is then shared with the World Health Organization, who tracks diseases. The CDC also shares that information on a more local level with state and local health departments as needed. So, for example, if they're finding that there's a rise in, let's say, type 2 diabetes in a specific geographical area, not only is that important for the whole United States to possibly know that information, but also for the individual state and region within the state that rise has occurred. It would be important for health officials to understand that to be able to create a plan of action to address it. While many people try their best for these rates to be reported correctly, there are many challenges, as you can imagine. So, for example, if you look over that list of diagnoses, you might see one related to something that you've experienced in the past. COVID-19 isn't a reportable condition, But many of you may have tested at home, decided to quarantine or isolate at home, and never reported it to your physician. And so that number over time, as the rise of home testing became popular, that number became less and less statistically accurate because people were just choosing to isolate at home, not seeking care. Here are some other measurements that we see. So, mortality statistics, again, this is looking at the incidence of death related to specific causes. So, for example, you can look up mortality statistics for breast cancer in the United States. Life expectancy, we talked about this a little bit the other day. So, life expectancy is again not looking at if the current life expectancy is 79 years old, that doesn't mean that if you're 25 years old that you're going to live to 79. You have to look at the year in which you were born and what the reported life expectancy was for that year. So that might differ. And again, that's just an average based off the data that they have available. Let's move forward here. So here in this chart, you can see some different life expectancies. They do break it out by male and female, and they look at life expectancy at birth, and then they recalculate it once that individual at 65 years and then at 75 years. And so it is not necessarily a useful prediction for individuals. It does not describe quality of life by any means, but it does give us information in terms of possibly looking at healthcare across the age spectrum, improving quality of life, or include improving length of life, not necessarily quality of life. Years of potential life lost is a statistic that is calculated looking at the years lost when death occurs before life expectancy. This is very difficult to determine. So basically, what they do is they use age 75 and they look at deaths that occur before age 75 to create this calculation. So, somebody who dies young has a more weighted number in this calculation than somebody who has died in older age. And it's just looking at how many years of life was lost potentially related to specific health outcomes. So there's not just one number, you need to look in reference to a specific outcome. So, for example, what is the years of potential life lost for individuals who have diabetes or who were involved in motor vehicle accidents, something like that. Some other measures are looking at disability adjusted life years. This is looking at more so quality of life, so the burden of disease. And one DALY, which is how they abbreviate that, is equivalent to a year lost in a healthy life, as well as looking at health adjusted life expectancy. This is looking at, again, more quality of life related to healthy life expected. So you might see these measures also reported for specific conditions, specific events. Now, data is going to come from a variety of different places. So it might be collected by the United States, such as in the US Census, which is taken every 10 years. The US Census is going to gather data like race, age, income, employment, housing. It might come from sources like the Vital Statistics Report, which is a summary of death, birth, divorce, marriage, and infant death rates that is reported under the CDC. It might be from sources like the MMWR, the Morbidity and Mortality Weekly Report. This is published by the CDC, but the information comes from states and looks at disease outbreaks. It looks at environmental hazards. It looks at morbidity and mortality rates, as well as other public health problems specific to that individual state. This type of data is then oftentimes used to create um, programs and plans that we're going to talk about in future classes. There's some other ways that they gather data, such as like the national health surveys. You can see the NHIS, the NHANES, and the NHCS are different surveys. Your book goes into a little bit of detail as to what these are looking at. But essentially, this is the government created surveys to help look at health measures and to gather data related to public health. This game, Stop the Outbreak, is a game that is created by the CDC that I highly recommend you take the time to play around with. This gives you a little bit of an idea of what an epidemiologist does and how epidemiology is used to stop outbreaks whenever there are outbreaks that have occurred. So, I would highly suggest you look into playing this game. In the field of epidemiology, then studies typically are going to be published so that individuals can use that information to create plans of attack if it's an outbreak, to create prevention methods when needed. And these studies are typically broken down into two types of studies. Descriptive studies are going to describe epidemics with respect to who, when, and where. So they're going to describe a lot of information about whatever the study is looking at, whereas analytics are going to test a hypothesis about relationships between that health problem and possible risk factors. So, for example, if we were looking at studies that were coming out early in the COVID-19 pandemic, they were largely descriptive in nature. We didn't know much about the disease. We didn't know the long-term ramifications. So those studies that were published came out and said, hey, this is what we know. This is where we know it's occurring. This is who we think might be more affected versus other. Whereas in the analytical level, we now see a lot of studies coming out that are looking at the effects of COVID long term and the effect of COVID on the body. And possibly how does the incidence of getting Omicron COVID affect individuals, let's say with diabetes? There might be a study that looks at just that. If an analytic study is observational in nature, it observes the natural course of the events, it doesn't intervene, versus an analytic study that is experimental. These types of studies are going to add some sort of intervention. And so maybe they're looking at the effects of a medication or a vaccination or a preventative plan versus just watching what happens over the course of time. This is a slide that highlights some of the different types of outcomes that you might see if you're looking around at epidemiologic studies. This looks at some of the epidemiology curves. So it might look at the common source. It might look at incubation period. It might look at patient sources. So variety of different things could be reported. So, for example, the first top left is looking at annual cases of Lyme disease year over year in the United States. The bottom left is looking at death from lung cancer and cigarette use. The top right is looking at countries with measles and comparing 2 years, versus the bottom right is looking at adult the rates of adult obesity in the United States just in the year 2020. So these are just some graphical representations of what some of these studies might look like. Again, in an interventional experimental study, typically there's some sort of placebo, so no treatment given or a false treatment to compare against those who are receiving some sort of intervention. And so, if it's a drug related study or a vaccine related study, part of the population will receive that intervention, so that specific drug or vaccine, whereas the other group will receive something like a vaccine or a shot that has, let's say, salt water in it compared to an actual vaccine, or a medication that's really just some made up of, sugar or salt or something that's safe to take versus an actual medication. And then looking at the differences between those groups. These studies are not always able to say that something causes something. So association does not always imply causation. Things might just be correlated without causing the relationship that they think that they are studying. So researchers are really aiming to identify, is there causation or just correlation? And when they do so, they're looking at the strength. How strong is that association? They're looking at dose response. Like, if you have greater exposure to something, does that mean that you're increasing your risk of that disease? They're looking at consistency. Does it occur across different people and settings? And can they replicate those studies in the future? They're looking at specificity. So is the disease associated with exposure, and is it always the same? They might look at temporality. Does exposure always come before the disease process? But also looking at biological plausibility. Does this causation make sense with what we know about current biological processes? And if not, is that really a causation or just an association? So all of those criteria might be taken into consideration. Thank you for looking at this information. There is a video below that I would like you to watch, linked right below this. Thank you.